Good afternoon, all. Welcome to our 14th session. So, today we are having SMRITI Rana taking a session on psychosocial issues for us. So, we can start with ma'am's presentation. We can have it for around 40 to 45 minutes, followed by 15 minutes of discussion. Around 4 o'clock, we can have our case presentation, followed by its discussion. We can wind up our session by 4:30. Thank you all for joining in. Over to Sunil sir.
So good afternoon. Till now we have been talking about physical symptoms and communication. But now we have another important aspect of patient care, which are the psychosocial aspects, which we usually neglect because of many reasons. But it is a very important area that we all have to be very careful and we have to manage it properly. Uh, so today's session will be handled by SMRITI Rana. Basically, she is a psychologist and she has been working in various health settings in different capacities. But as of now, she's working as the director of projects and programs of Padim India, and has been having good experience in palliative care. And I welcome Smriti. Welcome, Smriti, and it's over to you.
Thank you. Thanks, Dr. Sunil, and thank you, Raju. I'm really pleased to be here among such a illustrious group of doctors today. Um, I mean, like Dr. Sunil said, I've been involved with Pallium for a while, 7 years to be precise. And personally, I've been involved in palliative care for about 17 years. I have my interest in palliative care came from the fact that I was a caregiver, and nobody in my family at the time, there were a lot of people who were unwell, and nobody in the family actually received palliative care. So that was why when I was introduced to it, it really resonated with me. My training is as an integrative holistic psychologist, but over the years, of course, the multidisciplinary modality has really appealed to me. So thank you for having me, and I'll be happy to take questions as and when they come up. So I'm going to just start with our slides. Today we're going to talk about the psychosocial aspects of care. And along with my name, you can see Sharat Mohan. He was one of our medical social workers he's in the UK now, but then I have to give him due credit for actually formulating the bulk of this particular presentation. So to begin with, I think we're all very familiar with the WHO definition of palliative care. And I want to just highlight, so I'm not going to go over it repeatedly because it would be kind of, reinventing the wheel again. But I'd just like to highlight the parts in red. So the definition very clearly talks about prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. I know that as medical practitioners, you pay a lot of attention to assessment. I mean, that really forms the basis of the work that we do. Similarly, in in psychosocial aspects of care, that assessment becomes equally important. And it would be foolhardy for any of us to just go in and believe that, all we really need to do is listen to what the patient or the family has to say without actually following some sort of systematic and structured way of exploring the issues that they're facing, based on which, of course, plans of care are created. And we work closely with the entire multidisciplinary team to try and alleviate the suffering as much as we can. So why psychosocial care? I mean, I think, for a long time, palliative care was associated with end-of-life care for terminally ill cancer patients. I mean, those were some of the more commonly, that was the way most people commonly understood it. And of course, now that definition is quite expanded, especially in countries like ours, low to middle level income countries like ours, where there are no, where certain verticals that exist in the developed world don't exist here. So a lot of the people who would in other settings not be brought into palliative care have no other recourse but to receive our care in our kind of setting. For instance, um, I think a lot of people are quite surprised when we say that, we have people with spinal cord trauma in palliative care. We have people with renal failure in palliative care. And time again, I have seen that, that comes as a surprise. We ourselves work with a cohort of parents who have children with congenital anomalies. And in some settings, we find that when a mother gives birth to a child with an anomaly like that, very often she's abandoned by the rest of the family. And so then what you have is a young woman with a fairly sick child. She probably does not have the skills or the education to bring in an income. And she's on her own looking after a child, quite isolated from everyone. So in cases like that, that is also illness-related suffering. So to come back to what's on the slide, living with a life-limiting or life-threatening illness or the awareness of approaching death causes unique stresses and challenges. And apart from the physical distress that forms a major chunk of those challenges, we of course have other issues cropping up: psychosocial, socioeconomic, spiritual issues, so on and so forth. Understanding these factors related to a patient's quality of life is essential in providing appropriate care. And I'm not sure, for me, I came across this concept of total pain quite early in my career as a palliative care provider. And I'm not sure how familiar people here are with this concept, so I'm just going to take you through it. The idea of total pain really alludes to the fact that, we're all familiar with the pain scale of 1 to 10, where we ask people to score their subjective pain. And quite often, the pain that a person reports may seem a little bit, I wouldn't say exaggerated, but physically that person saying he's got 9 on 10 pain, when actually the physical symptoms don't indicate that that pain should be that high. So through all these years of working with our patients and our families, we find that the pain that somebody reports is actually compounded by their life circumstances. If I were to give you an example, I'd say, okay, imagine that you woke up one morning and you had a deadline to meet, you had lots of work to do, you had several patients to meet, and on that day, you wake up with a really terrible headache. And on your way to work, you have a flat tire, there's no one around to help. You get to work, your seniors shout at you because you're late, and then your whole day goes for a toss. And I suspect that that headache is going to feel 10 times worse than if you had the day off, you had the luxury of staying home, there was someone to care for you, and you could get the rest you needed. So I would say that on those 2 days, if I were to ask you to score your pain, I would get different numbers. So that's the idea of what total pain really is. And so as a clinician, my responsibility is to assess the contributive factors leading to total pain. So I need to check what's going on in this person's life right now that might be contributing to him or her feeling that pain more intensely than he otherwise would have. So if I were to put it diagrammatically, illness-related suffering is much more than just physical distress. Of course, as the medical fraternity, you've really elevated the science of medicine to massive heights. What we're really looking at is the other aspects of what contributes to a person's suffering. There are psychological aspects, there are socioeconomic aspects, like I said, and of course there are spiritual aspects, and all these together contribute to the person's experience of pain. Now let's take, for example, this lady. This is based on a real life case that we had in Pallium, India, some time back. The patient was a 27-year-old lady who we're going to call Mrs. D, and she was diagnosed with cancer of the rectum in 2014. She had chemotherapy and radiation, followed by a colostomy. She was referred for pain management. Now, at the time of registration, she presented with severe pain, infection, and a foul smell from the colostomy site. And these are things I'm sure everybody who's present here today can easily imagine. In addition to that, she looked very anxious and scared and had no idea about palliative care. So even the person who referred her to us had not even briefed her on what to expect when she comes to us. And from the medical records and present disease progression, the medical clinicians on our team had the impression of a very bad prognosis. She is married and her husband is 35 years old. He is a daily wage worker and her child is 6 years old and is going to school. So this is basically an introduction to Mrs. D. Now, coming from the point of view of psychosocial assessment, what are the important areas that need to be assessed from the point of view of total pain? So if you remember the diagram, there are 4 aspects. The physical aspects, of course, we leave to our very capable medical colleagues, but we look into the other aspects. Okay, so in her case, the aim of our assessment would really be to identify the problem areas which result from the illness, very specifically. What has the illness compounded in her life and may influence the well-being of her and her family. That's the aim. Now, what does the assessment involve? Of course, there's collecting information and identifying, ordering strengths, resources, and needs. Now, everybody here is also familiar with the genogram, right? So that is one way we collect information. That's to help us understand the structure of the family. We take it forward a little bit by then figuring out the dynamics between each person in that genogram. Now, typically in a genogram, people put down the patient who their husband or wife, the spouse might be, who the children are, whether they have parents, elderly parents or parents that live close to them or nearby, or parents who are deceased. But typically in our practice, we expand that genogram to include even people who don't live with the patient. Siblings, uncles and aunts who might be very influential in their lives, so on and so forth. So we do all of that. And then that helps us understand who forms the fabric of this person's life. Now, then we go into a deeper assessment of asking them about their personal details.
Smriti, we lost you.
Often we find that they've gone into some sort of debt or even multi-generational debt. Some people might have lost their jobs. Some people might have had to give up their career to look after the person at home. Very often we find that because of extreme treatment costs, resources are reallocated. For example, a child's school fees is now being used for treatment. So the child's education is interrupted. There are several things like that we discover. We also try and find out what the strengths within the family are. Who talks to whom? Who they look to for comfort, who they look to for support. It may not even be within the family, it might be in the community. Some people are very, for example, a church group or a group of friends. So those kind of things, we factor in all those things that give them strength and comfort, and we honor it, and we also then make a note of who we can go to help strengthen this family support system a little bit better. And of course, assessment and gathering of information is an ongoing process. It doesn't stop with just our first interview or the second. In fact, in a lot of cases, after the initial rapport building and family history and all of that is taken, when we know that we've earned the trust of the family or the patient or the caregiver, we go into more in-depth analysis of things that might be a little bit more difficult to talk about. For example, their spiritual concerns. That's not an easy conversation to have the first time you meet them. In the case of some of our patients who have spinal cord trauma and wheelchair bound, some of them are very young. We find it quite important to go into their difficulties that they face with their intimate lives, with sexuality issues and stuff. And again, these are not things that we can talk about right up front. So it's an ongoing process, and that ongoing process largely depends on the kind of rapport that we're able to build and maintain, and ensure that the patient feels safe in our presence. Now, the psychosocial needs of patients and family caregivers often change over the course of the illness. And this is something that is true of every case that we see. What they initially present with over time changes, depending on the kind of support and care that they're able to receive from our team. And
Hello.
priorities might change.
Hello. Hello.
Dr. Srinidhi,
Hello.
Yes, yes.
we can hear you, Dr. Srinidhi.
Yes. Who's speaking? Dr. Srinidhi? Is it Dr.
Hello, Dr. Srinidhi. Dr.
Yes, sir, please. Please tell us.
Ma'am, you can continue, ma'am.
And Smriti,
All right.
please come closer to the microphone.
Okay, is this better?
Yes, yes.
All right. Okay, so what I was saying is that the psychosocial needs of patients and families or the caregivers often change over the course of the illness. And that largely depends on the amount of support that we're able to give, of course. But as the illness progresses, the goals of care also change. And physical goals of care might change in terms of mobility, in terms of distress management, and so on. But concurrently, so do the psychosocial needs. And that is something that we're constantly vigilant of, and we make sure that we track, and we also try and anticipate some of the needs that might emerge as the illness trajectory changes. So when assessing psychosocial and spiritual suffering, a lot of planning has to go into what it is that we're going into this meeting for. Very often the idea of psychosocial support is, we go in there, it's about just listening to what the patient has to say, give them some level of comfort, allow them to ventilate their feelings. All that is part and parcel. But of course, going into a meeting, we need to understand what we would like to see as an outcome of this meeting. So it's very purposeful observations. We might be looking specifically at their non-verbal cues, at their body language. As important as what a person says, just as important is what they're not saying. And that's for us to really hone our senses and to be tuned into that. And our conversations also need to be purposeful. Just sort of saying comforting things or saying, don't worry, it will be all right, that really serves no purpose. Giving, false hope, that's very easy to do. And sometimes it's almost a defense mechanism that we as human beings have. But that is something we need to be very, very careful of when we're having these conversations with our patients and their families. So purposeful observations, purposeful conversations, keeping very, very close track on what is being said, how it is being said, being careful not to say something that might lose the trust of the patient, and making sure that if we set goals with them, we follow up on those goals. And if we say that we're going to provide a certain kind of support, make sure that it's within our capacity to provide it, and then of course follow through with the provision. Now, there are several possible psychological kinds of impact of an illness on a person. And unlike a physical symptom that manifests or can be can be assessed through a scan or a probe or or an MRI or whatever, psychosocial and spiritual suffering has no real measurable yardstick like that. I mean, there are of course assessment tools and things which are quantifiable, but if you really go into the heart of it, beyond a certain point, you're on very nebulous territory. And of course, there might be feelings of shock that they have this illness in the first place. I mean, a lot of people, till they actually get diagnosed with something like cancer, is always something that happens to somebody else. So the feeling of shock can be there. Of course, there is uncertainty. there's a loss of hope. I mean, it's mentioned as hope, but I would say there's a loss of hope, there's despair. A lot of people feel like they've lost control over their lives. And that sense of losing that sense of control can be terrifying to most of us. There is, of course, something called anticipatory grief for things that you're about to lose, things that you think are at risk. It could be, anticipatory grief is, it's grief in anticipation of an event that is yet to happen. Now, a lot of people associate that with death, but it doesn't necessarily have to be death itself. It could be the loss of a limb. It could be the loss of a function. It could be the loss of your role. If I am the person in the household that really looks after the kids and makes sure they're going to school and all of that, once I'm sick, I lose that ability to perform that role, and that can also cause me a lot of grief. Poor insight on diagnosis and prognosis causes a lot of fear also, because we're all afraid of the unknown, right? And if we're not able to really understand what the complexities of our illness is, then that causes a lot of anxiety as well. But I would like to point out that poor insight on diagnosis and prognosis, it's really not on the patient or the caregiver. It's on us as the healthcare providers to make sure that our information that we're disseminating to them is clear. And we need to give them that information as many times as they need it. Many years ago, I heard, and I mean this with no offense to anybody here, but I heard a doctor say that, I've explained this to this patient so many times, they just haven't understood it. Now, what more can I do? My question there would be, what is it in our communication that is creating that barrier? Are we not speaking the language of the patient? And sometimes we have to de-jargonize our own language in order to make ourselves more effectively understood by the patient or the family that we're talking to. Anxiety about death, of course, that is a very common thing. But if we were to dig deeper, I find that a significant number of people are not really worried about the event of the death itself. It's how they're going to die. And that is something that comes up time and time again. Are you afraid of death or are you afraid of dying? There are two very different answers to that. And a lot of people are more afraid of the suffering that they might encounter along the way rather than the actual event of passing away. Thoughts of suicide or wanting to hasten death. Thoughts of suicide almost always occur when there is unmanageable distress. In our country, I'm sure some of you are familiar with this statistic. 1 in 5 suicides are committed by people who have a chronic illness. And that is a really staggering statistic to have. So it really should make us wonder what we're not doing for them that wants them to end their life. Wanting to hasten death could also have the component of, feeling like you're a burden on the family, either psychologically, emotionally, or financially. A lot of people feel that the cost of their treatment is devastating their families, and they would rather not be around, long enough to cause that kind of devastation. So those could also be reasons. Socioeconomic reasons could also propagate this thought. And of course, poor coping with the illness itself. And I don't mean just physically, mentally and emotionally. And in families that have shown traits of dysfunction prior to the illness, a crisis like an illness enhances the dysfunction in the family. Whereas a family that had good coping skills together, was a cohesive family prior to the illness, tends to rally around the patient more, and they tend to do better in an illness setting. So also it's important for us in our assessment to try and find out what was their family life like before the illness came. Did they talk to each other openly? Who made the decisions in the family? Who are the people they were afraid to talk to? Who are the people that there were hostilities with? Now, if we understand that landscape, we also know going forward which relationships could be damaging or could be facilitatory in the coping process with the illness. And very often, psychosocial and spiritual suffering can manifest as physical complaints. Now, this is an area which I know is difficult for a lot of us to really absorb and get our heads around. But I mean, uh, it is a fact that if there is some sort of psychosocial issue or psychological or emotional issue, it definitely affects our health, and that's something that we can all agree with. How it manifests, of course, is a case to case study, and we need to be really sensitive about how we talk to the person about it. There's no textbook formula that we can really follow. Very quickly, I'm going to touch upon aspects of spiritual assessment, because how do you assess somebody's spiritual suffering? There is actually this tool that was developed, and I have used it extensively in my practice, and I have found that it is a very, very effective tool to have those conversations. Now, I want to make it quite clear here that when I talk about spirituality, we're not talking about only religious belief and faith. We're talking about what helps a person feel connected to the world and gives them meaning in their lives. For some people, it is their faith. For some people, it might be a connection with the natural world. For some people, it might be a connection with their grandchildren. For some people, it might be their role and the function they perform in society, how they contribute to the well-being of their community. These are all aspects of spiritual care. And if you look at the areas of assessment, it's quite stark what we're talking about. Connection. Now, on the other column is how do we assess it? Now, who are the persons or communities you look to for support? What role do they have in your care? Do you have an image of a power greater than yourself? Has your life situation now affected your feelings about yourself, your faith, or your relationships? These are just some of the Q questions that we can ask. Of course, we would have to contextualize it to the kind of patients that we are working with. And it's not a one-shoe-fits-all question. We have to sensitize it to the person that we are speaking with. Meaning and joy. What has been most important in your life? What are you most thankful for? What makes or has made you happy? What do you feel the proudest of in your life? To me, this particular section is very important, because very often in the conversations we have about illness, we focus on the negative. We focus on what the illness has taken away. And it's very, very difficult to think of anything remotely joyful. But if we introduce this into our conversations, it's not only useful, but it's also essential in reframing the person's perspective, and also helping them remember that, yes, there are good things in their life still. Strength and comfort. Is there anything that is comforting you right now? What helped you get through difficult times in the past? Who or what is your source of strength now? Now, if I as a clinician understand what has helped them get through difficult times in the past, maybe I can facilitate them reaching out to that again. These are really important things to ask also when you're trying to reinstate some sort of realistic hope in the person, right? And of course, hopes and concerns. Is there anything that you hope for? Is there anything that feels unfinished? Many of us are scared to ask this question. Is there anything that you hope for? Because the answer we feel might be, yes, I hope I don't die, which is not something that any of us have any control over. And that's an area that many of us professionals, no matter how much experience we have under our belt, we really struggle with. But here, there is a way to also reframe that and shift the framework of hope from something that may not be achievable to something that can be done. And then that becomes smaller, achievable goals that we can set targets for. So this is something that I would urge you all to explore a little bit more in your practice if you haven't already made it a part of your practice, because it is really a great way to form a deeper connection with the families that we serve. So when we assessed Mrs. D, the patient whose case I presented a few slides ago, this is what we found. Physically, she was unclear about her prognosis. There was, of course, discomfort due to the colostomy bag. She was fatigued, and she hadn't slept very well in a long time. From a psychosocial perspective, her relationship with her husband and his family was now strained. The colostomy bag made her feel humiliated. She was hesitant to go out and interact with people because of her colostomy bag, and that was causing her further isolation. Of course, there was anxiety about the future of herself, the future of of her child, and there seemed to be a generalized fear that she couldn't put her finger on. She was just feeling very, very fearful. Socioeconomically, we found that because her husband had his caregiving duties, being a daily wage worker, he lost wages, and that was causing a lot of stress on the family financially. Uh, this was having a domino effect on the fact that now they were worried about the educational expenses for the child. Is the child going to have to stop going to school? And because she lived in a very rural area, access to the hospital was very, very difficult. So these were practical issues also that they were facing. And spiritually, she was in extreme spiritual distress. She couldn't understand why she had to suffer so much in spite of being a strong believer in God. She felt that she was being punished for something that she didn't understand she had done. She felt a loss of connection with her family and friends and community, and that is directly tied to her psychosocial isolation. And there was a loss of interest in pleasurable activities. So really, she was just feeling all of these things, and that was of course contributing to her total experience. I'm going to now segue a little bit into the idea of dignity, because it is closely tied with some of the things that we're talking about. And I would say one of the biggest things that illness takes away is a sense of dignity in a person. So dignity therapy is now emerging as a very, very strong field. There's 20 years worth of evidence-based research that has gone into it. It's not just something that we talk about anymore. There are very well-researched interventions that we can do, and the results have been phenomenal across the board. So this is something that we try and imbibe in our practice as much as possible. I'm going to ask you to take a minute to give this word a thought. Okay, dignity. Um, Dignity is like the word love, or it's like the word joy. We all know that it's important, it's vital to our lives. But if I were to ask you to break down that definition and say, what does love or joy or dignity mean to you? All our answers are different. So there's no definition for it. It is a very, very subjective thing. And we as clinicians, the inability to acknowledge personhood, the insensitivity of not acknowledging personhood can be psychologically devastating. If I don't recognize what gives a person dignity and only treat them for symptoms, only treat them as recipients of some sort of financial support or whatever, I'm really not looking at them as a person. And yes, that can be psychologically devastating. If I'm seen as just a number on a chart or just a name on a case file, I'm being robbed of my personhood. It's denying my whole story. It's denying what I've gone through in life. It's denying what it has taken for me to be here. It denies what I mean to different people in my life. So all of those things are taken away if we don't acknowledge that someone in front of us is a person and not just another statistic. The ABCD of dignity conserving care. Now, if you go into dignity therapy, there are different aspects. One of them is dignity conserving interventions. And if I were to break it down very quickly, the ABCD would be this: attitude, behavior, compassion, and dialogue. And all of you being doctors, I'm sure are acutely aware of the new introduction of the 8COM module, right? Attitude, ethics, and communication, which is all about this. So there's a lot of cross-pollination of ideas between dignity conserving care and the 8COM module and palliative care. So it's all really talking about the same thing. Harvey Max Chochinov is actually the author of the book Dignity Therapy. And if any of you are interested, I highly recommend this book. He says that people experiencing a loss of dignity have significantly higher rates of depression, anxiety, and feelings of hopelessness. And this is done after years of research. This statement has been made. Now, I don't think any of us can really argue this point, right? If I lose my dignity, then it's going to affect me on several levels. So here is what this is called the dignity question. And the dignity question is quite simple. What do I need to know about you to help you better? It's a simple question. But if you start using it in your practice, you will find that different people have different answers. Some people might say, I was abandoned as a child by my father. What does that have to do with how I can help this person today? He might have fear of abandonment. Okay, so what can I do as a healthcare provider? I can assure him that I will not abandon him. Someone might say, oh, I like to eat ice cream, which is a completely different answer from what the previous person said. But what that tells me is that the person takes pleasure in the small things, and I'll try and at least make sure that he has access to that. Other helpful questions that you could ask are these: in terms of your illness experience, how do you define your dignity? Rather than us assuming what brings that person dignity, it's always better to ask them, what supports your sense of dignity? So again, these are questions that you'll have to contextualize, and our team is happy to help you with that. Do you believe that dignity is something you hold within you? Or is it something that can be given or taken away by others? And more than asking your patients this, I would ask you to ask yourselves this first. Think of this as a reflective exercise, and maybe take a few minutes today or in the course of the week to really sort of look at these questions from your own personal perspectives. And then that'll enhance your ability to empathize when you ask questions like these to your patients. Very quickly, I'm just going to take you through some pictures. We're almost out of time. These are some of our patients' experiences we've had, and like it says here, we did take consent from everybody. Here's a man who was he didn't have very long time to live, and if you look at the cake, it says advanced wedding anniversary. It was anticipated that he wouldn't be around for their wedding anniversary, so we celebrated it in advance, and that gave them a little bit of joy and something to remember as a good memory. For some patients, dignity is maintained if something of their essence will survive beyond the event of death itself, legacy. A lot of our patients are worried about what will happen to family members after they're gone. Some of them wonder, what difference did my life make to the world? That's the legacy question. And here, what we do is patients are asked to speak either on tape or about various aspects of life they would most want permanently recorded, or people to remember them for, and things which they feel are most important and would most want their loved ones to remember. Legacy exercises can also include writing letters to young children that can be given to them at milestone years, so on and so forth. So if you look at the dignity therapy book, there are lots of these suggestions for how we can enhance our practice. And of course, psychosocial interventions, I'm not going to go into any detail. It would be impossible for me to do that. Would include family meetings, supportive counseling, cognitive behavior therapy-based communication. I want to now say that there's a new kind of CBT, which is less Western and more integrative with esoteric practices. It's called mindfulness integrated CBT, which I find very particularly helpful in my practice. Of course, bereavement support services, recommendation for government schemes and other financial assistance to enable people to not be, ruined by healthcare cost. Linking with community resources like women's groups, children's groups, education support, so on and so forth. Vocational training for people so that they can operate out of their own homes sometimes. For people who have been, you know, had spinal cord trauma, for instance, we did vocational training with them, and 6 of them became chefs, and they re-engaged with life. So you can get very imaginative with vocational training also. And of course, regular follow-ups. That's really important. I mean, once we empower somebody using any of these techniques, it's really important to go back to them and see if it's working and if something needs to be changed. There are several things we do with vocational rehabilitation. Like I said, you can get quite imaginative. For some people, they like rearing goats. For some people, they make pens and things like that, stitching, umbrella making. So whatever it is that suits that person. So it's very important here not to impose our ideas, but also to find what works for them. If I give a woman caregiver who's dealing with a sick person in the family some goats to look after, I might actually be doing her a disservice and adding to her burden. So these are things that we have to be careful of. And of course, support for children is a big winner, because very often patients are worried about their kids. And if in some way we can bridge that gap and make sure that the education is not supported, they're part of a peer group that is also going through similar issues in life, then that's a tremendous help to the kids as well as to the families. And just as a cautionary word, even we as psychosocial clinicians, we have to evaluate our interventions. We have to assess how the patients and families have benefited, whether we're actually adding to their burden or really taking away. Good documentation is as invaluable in psychosocial care as it is in medical practice. And wherever possible, we have to use research validated techniques and not just go by intuition of what we think we should be doing. And of course, there is an art and science in psychosocial care, just as is in medicine. So that's it for now, Raju. I'll stop sharing the screen.
So thank you, Smriti, for this session. So all of you have got some idea about why the psychosocial assessment is important. Psychosocial and spiritual assessment is important, and she also touched upon dignity therapy. And when we see patients, it is very important that we should see them as a dignified person, and we should ask them what are the things that give you the dignity, and what all can I do for your dignity. So all those questions are important. Um, the session is open to discussion, and anybody can have any comments or queries. Okay, there is a chat question. What mode of psychotherapy would you do frequently for palliative care patients?
So what I find is that there is no particular school of uh, there are various schools of psychotherapy, right? So there's, of course, there's psychotherapy as we know it, the Freudian one. There's the Jungian approach. There's there's CBT, which is the most commonly bandied about. There's REBT, which is rational emotive behavior therapy, and so on. But really, I would say that uh, in my own practice and in what I would recommend is an eclectic blended approach. I really need to see what the person is about, what their modality is, and then work with that modality. So I would think that if a person is cognitively capable, then I would use CBT. I cannot use CBT on somebody who's cognitively not able to have those kind of conversations or to be challenged in their beliefs a little bit. Now, REBT, for instance, is a very I wouldn't say very, but it's a sort of confrontational exercise. I can't use it on a person who shies away from confrontation. So just like you would sort of look into your experience in medical practice and see what would work best in that moment, so would I. So I wouldn't prescribe any one kind of psychotherapeutic intervention. I would really look at it from different aspects. Sometimes just being quiet with a person is very, very therapeutic. So I find that as psychologists, sometimes we feel the need to fill a gap, but just being present with a person sometimes is immensely therapeutic to them. So eclectic practices.
And so Dr. Geeta says children, it would be even more difficult to assess the problems.
So in our medical social work, team as well, we're running a concurrent echo program for for psychosocial clinicians, but we do talk about how to speak with children, how to communicate with children, and that by itself is an art and science on its own. It involves understanding where they are in their developmental milestones, how much. There is a huge aspect of of neurological sciences also involved, like where are they in terms of their cognitive development, how do they understand words, whether words actually are useful in a particular context. Very young children, for example, take things literally. They're not able to think in abstracts. So if I, like for example, if a child says what happened to grandma when she died, when she dies, someone says, oh, she goes to sleep and doesn't wake up. For a child who takes language literally, that's a very scary thing to say, because that child might develop a fear of going to sleep. Again, there's a whole body of work that pertains particularly to dealing with children. And I'll be very happy to share some resource material on that. I also understand someone asked a question about depression and anxiety. Yes, there are scales. There are quick screening tools as well as slightly more in-depth tools. Raju, if it's okay, then maybe after the session in the course of the week, I can share that also with this group, and all of you can choose what to use in the settings that you work in.
This tells us that some other tools for spiritual assessment are hope and spirit, and fika. That's another one which is
Fika.
usually used.
Yeah, fika is a really effective tool as well. Yes.
And Dr. Leela has come up with another comment. We see children with chronic diseases. In neurological diseases, the patient doesn't understand at all. But in kidney diseases, children are really aware and they require a lot of help. I think the primary care physician has a lot of responsibility.
Yes, and well, I won't speak for the physicians, but as a multidisciplinary team, I think especially when we see children with chronic illnesses and children who have something like cerebral palsy and things like that, where they're not able to communicate much, it's very, very important to provide support to the families, to educate the mothers, to educate the not just them. I mean, the mothers are a lot of them unfailingly kind and supportive, but also to educate the community around the mother. To destigmatize it. I mean, it's a very happy coincidence that this session today is happening on World Mental Health Day. I don't think it was planned like that at first, but I think strengthening the system around these parents is vital. And one of the, I just want to, I mean, this is something that I think I feel very passionately about, is when there is a sick child in the family, we really need to make an effort to keep an eye out for the sibling. The sibling becomes the neglected person in the family and becomes the invisible patient, and over time will develop behavioral problems and so on. So that is something that I will urge every clinician to always keep an eye out. If you're treating a sick child, is there a sibling in the family that you need to pay attention to? So that's really, really important. Okay. I see a question about suicide. Suicide risk assessment and suicide prevention. Again, very, very important subject for all of us to familiarize ourselves with. There are ways to assess suicide that sometimes, very often when we teach those risk assessment techniques, the response I get is, but that's so counterintuitive. One of the most important questions to ask a person who you suspect is feeling suicidal is to be direct with them and say, are you thinking of harming yourself? Are you thinking about, have you had thoughts lately of ending your life? Now, typically the response I get to that is, aren't we giving him that idea? We're not. We're actually unburdening him or her. It's like, to say that asking somebody if they're feeling suicidal is giving them the idea is like one of you doctors asking somebody about their heart condition and actually inducing a heart condition by asking the question. It doesn't work like that. Very often asking that tough question, which no one else is going to ask them, makes them feel like they're really being seen, that their suffering is being recognized. And after that initial question, it actually becomes easier to have the remaining questions, which again are difficult questions. I'm not asking you to go out into your practice and do this tomorrow, but please do your research about it. The next question would be to assess how imminent is the threat. So if I ask, okay, have you, and I'm sort of paraphrasing here, if I ask them, have you thought about ending your life, and they say yes, then I might ask them in a more sensitive way, how would you do it? I mean, have you thought about how you're going to do it? And you'll be surprised how many people have a plan. That plan will tell me how imminent the threat is. It's so there's a whole science to that. please go ahead and read it. And by the end of, I've had a few conversations like these with patients and also caregivers. They're a huge high risk group. But just at the end of a really honest conversation like that, they feel a lot less, uh, they feel a lot better. They feel a little lighter that somebody has actually asked them these things. But of course, you need to monitor, you need to make sure that you need to also see there are certain factors that might contribute to them actually going through with it. A history of suicide in the family, a history of past attempts, all of these are precipitating factors. There are factors that are harm reducing, like the presence of a child that they love very much, other supportive things. So look out for those things. What does this person have, and what are the precipitating factors that this person also has in their family that might make them higher risk? So that is a whole other module on its own. But yeah, in a nutshell, that's what I would say. You need to have that very honest conversation with somebody that you think is at risk for suicide.
So Smriti, we also do some risk assessment for vulnerable patients or vulnerable caregivers also, isn't it? So we see whether these patients,
Abs-
yeah.
I mean, Dr. Sunil, you're in I mean, in your practice also, I think you must have come across lots of caregivers who are so burnt out and so exhausted that, for them, suicide is the way out. And I think, yes, like we keep an eye on the patient, it's really important to keep an eye on the caregivers and how close to the edge they are.
Okay. So Smriti, Dr. Jaydeep is a psychiatrist. Mm. So,
Oh, great. All right. All right.
and Dr. Gray says some of the physical manifestations of psychological disorders are somatoform disorders or conversion disorders. That's true, isn't it?
Absolutely.
Yeah.
Absolutely.
And there are many patients who come up with severe pain, and once we address the psychosocial problems, most of them will have that pain gone away or it is reduced. So we will try to increase the dosage of analgesics, which they usually don't respond. And once we address other problems, then usually their pain also comes down. And there are these are problems with many patients with chronic pain. So it is very important to see whether they are suffering from any psychosocial or spiritual distress.
Absolutely. I mean, I'm so glad you made that point because, like you said, you can keep increasing the analgesics, but it's really not going to make a difference if we haven't looked at what is really causing them the psychological and spiritual pain that they're feeling. So, yes, absolutely. And I think that's the beauty of a multidisciplinary team, that we're able to exchange these notes and address it from a holistic point of view. Thank you, Dr. Sunil.
Anybody else has any comments or questions? So from this all interactions, what we have to understand is addressing the psychosocial and spiritual distress is important for the whole person care, and then only we address the total pain. And we also talked about children, and it is also important to see the siblings of the deceased child is addressed, or not only deceased child. Whenever there is children in the family, they also should have some information about what is happening, and why the other person is getting more care, and why you are not getting the care that you have previously getting. All those are very important. Otherwise, the children will feel that they are neglected. So it is very important. So
Sorry, I just
yes,
may I just add one more point as a closing remark from my side. Again, because this is something that I feel quite strongly about, having been a caregiver myself. Um, the word sometimes that is used, not sometimes, more often than is necessary, is the word bystander. So often we use the word bystander bystander to talk about somebody who is the primary caregiver. And I know it's just, sometimes words don't mean much, but in this case, I find that, the definition of a bystander is someone who stands by and doesn't do much. But by using that term, we're really dishonoring what a caregiver does, because they're on the front lines of that suffering. So if I may make a very humble request, is to urge your teams to also stop using that word, and because it goes a long way in restoring somebody's dignity by not calling them that something that dismissive. So that's a request I would make to everybody present here today.
Thank you, Smriti, for those points. And now we can move on to a patient story, which will be presented by Dr. Bhavana, who is the Associate Professor at GCRI Ahmedabad. Madam, it's over to you.
Good afternoon, everyone. I'm Dr. Bhavana Patel, Associate Professor Palliative Medicine, GCRI Ahmedabad. Slide, please. Today we are presenting a case with a malignant wound and having some psychosocial issues also. Patient is 57 years old, male patient, having recurrent carcinoma of gingival surface. Next. Presenting complaint, patient had oral ulcer since 1 year, inability to open mouth adequately since 10 months, pain over left buccal mucosa radiating to ear of same side since 10 months, and mass over left cheek at angle of mandible since 8 years. 8 months, here it is 8 months. Insomnia and constant thoughts, pain while chewing and eating, and constipation since last few weeks. Next. Patient was operated for same lesion in 2012 and completed chemotherapy and radiotherapy. He was on regular follow-up for 5 years, and he was operated for right side R&D in 2016. Later, he didn't come for follow-up. Now, patient developed a non-healing ulcer over left buccal mucosa before 1 year and was on alternative medicine in hope to avoid surgery and other side effects of chemotherapy and radiotherapy in past, what he experienced. He later developed trismus, which was interfering in chewing. So oral intake was decreased, and there was inability to maintain oral hygiene also. Later, he developed a mass over left cheek at angle of mandible. Then he came for follow-up in March 2019. He is a tobacco chewer since 15 years, and he is having mixed type of pain. He was concerned about ulcer and fungating mass, which was not healing. Next. On examination, there was irregular mass of 3 by 2 centimeters over left cheek, fungating with pinkish purple irregular margin and foul smelling with maggots. Oral ulceration was there, mucositis, trismus, and poor oral hygiene was there. Neck nodes were palpable, and vitals were near stable. Pain was there, severe pain, and patient was ECOG status 2. Next. Patient received 2 cycles of neoadjuvant chemotherapy given at the interval of 21 days. Last one, 6th of April, and concluded palliative radiation therapy before 2 months. These are investigations. Chest X-ray was normal. Other investigations were okay, and latest blood investigations were nothing significant. Next. Psychosocial aspects. As the disease regression is not there, it was palliative CTRT. Patient and family were had feeling of guilt and little depression because they went for some alternative treatment therapies and didn't follow up. He has no issue of social support, but just negligence was for wound care despite proper. Just a minute. I want to see. Previous one, please. Yeah, I see. This was proper guidance from palliative medicine department. Maybe again turn to some alternative medicine or some blind faith and hiding from that patients and relatives were hiding from us. He didn't feel comfortable to allow his family members to do his dressing also. A patient was feeling homebound because of foul smelling wound. Cosmetic appearance was bothersome to him even before it started smelling bad. as his son says. His son was also feeling very much guilty and he was crying. Treatment is covered under Ma Yojana, so no any financial problem. Next. On admission, patient was admitted to our hospice and tablet morphine is given, Q4D, perinom, bisacodyl, amitriptyline and pantoprazole was given. Injection paracetamol before every dressing, 1 gram before each dressing, twice a day. Gargle with betadine and metrogyl, Swiss and spit. Lignocaine viscous for Swiss and swallow. And we gave triple therapy with third tablet ivermectin, 12 milligram OD for 3 days, tablet albendazole 400 milligram BD for 3 days, and tablet clindamycin 300 milligram TDS for 5 days. Turpentine dressing and careful removal of maggots with tweezers twice a day. Later metrogyl tablet crush and paste for local application over wound. Next. Main concern was pain and fungating wound. Guilt of loss to follow up. Family is concerned, will he be fine? A lack of prognosis, counseling, and little bit in denial phase. Next. 57-year-old male with recurrent carcinoma of GBS received 2 cycles of CT and 10 fraction 30 gyri palliative radiation with complaint of pain, oral ulcer, fungating wound, and insomnia. Next. Here are few points for discussion. Anything to add in medical management for this patient for his fungating wound? How to deal with patient's spiritual and psychological issues? Need to add any more antidepressant, or is amitriptyline HS is 20 milligram is sufficient, which is prescribed by for neuropathic pain? How to counsel him about prognosis? Is he has just to live and that's why roaming here and there in hope to be cured? Should we tell truth and break denial? Thank you.
Thank you, madam, for presenting this patient story, which has many psychosocial and spiritual aspects. So, it's a 57-year-old man with recurrent carcinoma of the buccal mucosa, and who received chemotherapy and radiation also. Main problems were pain, oral ulcers, fungating wound, and insomnia. So the points to be discussed are anything to be added in the medical management. So anybody has any suggestions regarding this? Smriti, there are two or at least one medical question, and the rest are psychosocial and spiritual issues. So we will just take opinion from others about is there any other medical management to be done in this patient. What do you all feel? Are there anything to be added, or madam, is his pain is controlled with medications?
Pardon?
Is pain controlled with the medications, present medication?
It was adequate.
It is adequate. Okay. And is there foul smell present, or
Everything is on all smelling and maggots were cleared within 3 days.
okay? So from the medical aspect, he doesn't have much physical symptom, isn't it?
Right.
So with the present medication, I think it is very well controlled. Maybe I think we can also tell the patient about how to prevent further recurrence of maggots, because how to clean and keep dressing, and if maybe using a mosquito net will also help the patient to prevent further recurrence of maggots, which I think as explanations about this is very important. Anybody else has any suggestion regarding medical management? Another thing is, I understand that before each dressing change, patient has pain, and is it controlled with the paracetamol, or is it? Do we need to give something else? What do you feel, madam?
Yes, Dr. Sunil, are you asking me?
Yes, madam. Yes, madam.
Yes, pain of dressing is controlled with paracetamol. Otherwise, morphine is going round the clock. So there is no issue of pain.
Okay, one thing is that we usually give morphine because injection paracetamol is costly. And when we send the patient home, then it will be another problem. But if it is well controlled with the type paracetamol, I think it would be okay. Otherwise, I think we can advise them to take morphine 1 hour before each dressing change. But I understand that in your hospital setting, patients, the medicines are given free. Yeah. Another point would be the how to clean the mouth, or how to keep the oral hygiene properly. So what we usually do is asking the patient to make a homemade saline, and adding a little bit of baking soda to that, and ask them to spit it out, wash it and spit it out every 2 hours. So that's what we usually do. And as you have rightly told, Metrogyl injection can be added to that, so that will also help to reduce the false smell. Okay. Sorry. Dr. Jidin, are you there? No. Okay. So, madam, just wanted to know, is he clinically depressed?
Not much, but all the time he discuss about whether he would have not gone there, and he would have come here earlier, then it won't happen.
So I think we can have more assessment of depression, whether is he finding pleasure in the previous activities, or does he has any thought about suicide, which are important, hopelessness, which is not proportional to the disease what he has now. All those things need to be assessed. Sruti, I think you can also contribute to this.
Okay, so I would also look into this is something that I feel that is a distinction to make. There is a difference between grief and depression. And, I mean, of course, there are ways to assess clinical depression. There are several parameters by which we can quite accurately, diagnose it. But I would also perhaps think, okay, I mean, in his condition where he has a disfigurement practically on his face, and he's gone through this pretty awful ordeal of this fungating wound that is foul smelling, all of that. I mean, anyone in his place would be feeling quite low. It's not like a wound that can be hidden with clothes. It's literally there on your face. Like you look in the mirror and you see it. There's no escaping it. So I would also caution against jumping into the diagnosis of depression, and also see what is he grieving about. I have a couple of questions which will probably help me, sort of be a little bit more, I think, accurate in my. I don't want to guess. One is what did he do before his illness? I mean, what was his job? As in, what sort of a livelihood did he have?
Farmer, shopkeeper. He was a shopkeeper, ma'am.
Okay, and okay, he was a shopkeeper. And the other question I wanted to ask is, how old is his son?
His son was about 30 years.
30. Okay, fine. I think being a shopkeeper, he's used to also dealing with a lot of people and, like meeting a lot of people in the course of his day and things like that. Now, with a wound like this on his face, it must be really humiliating to go out. I mean, of course, with your care, now you've said that you managed to like clean the wound and it's now no longer foul smelling. Of course, that's such a big relief. But I imagine that when you first came across him, things must have been so much more terrible, right? So and so that whole part of his life is also gone, where he's able to socialize, where he's able to face people, literally face people. Now he doesn't even feel like he can do that. So there is isolation, of course, there are isolation issues. I remember you said that he was uncomfortable with his family changing his dressing. I mean, being the head of the family, to be in that really vulnerable position, to have other people see him like that and be at literally at their mercy, it must be really it must be quite a blow to the head of the family to be in that position. uh, so I would imagine that having that conversation between him and his son and saying that it's okay to ask for help, and it's in no means it's not demeaning you in front of your children or in front of your wife, to be able to manage this wound together as a family, right? um, the other thing that stood out for me was the sense of guilt. That was a recurring theme. Um, Maybe before he came to you, he went to a couple of places where they reinstated that guilt. They reinforced it, saying, why did you do all that? You should have just come to us first. And I think that kind of thing it's very hard on a patient and the family, because if you really think about it, nobody wants to torture the person who's sick, right? They're only doing what they think is right in that moment. So if somebody has taken him to, or if he's gone to seek alternative uh, healing techniques or whatever, it's probably because he and the family at the time thought that what they were doing was right. I don't think as a healthcare system we should make them feel bad for doing their best. They don't have the knowledge that most other people might have. So I think that guilt is a terrible thing to carry, and he probably feels that he's putting his family through all this because of his doctor shopping that he's done. But I think as a first line, as a team, what I would really do is address that guilt, relieve him of that guilt, relieve him of it, and speak to him and his family and say, listen, we're not judging you. I think what you did was what you thought was best for him at the time. So let's work with what we have now. So I think guilt goes a long way in adding to somebody's suffering. So as a team, I definitely try and reduce that. Um, and I think it'll take some time to sort of because, like I said, it's such an obvious thing. This wound on his face. Uh, I would definitely work with the spirituality tool, the one that I shared. That I find is a great way to get insight into what the man might want to still do in order to re-engage, in order to still make him feel less isolated and stuff. I find that is a very, very valuable tool in also understanding what the family can do and making them feel a little less helpless in a situation like this. So I'm just right at the moment, I'm just sort of um, addressing point number 2, the bullet point number 2. So I'm happy to hear from everybody else. And I think a lot of you have worked in are working in multidisciplinary teams. So the question about how to counsel him about prognosis, I think is something that there are many other people in this Are you here?
Okay. Yeah. So, so this person is in denial, madam. What does he talk about his disease? Is he agreeing that he has a recurrence of disease, or is he not agreeing that he is having recurrence?
Sorry, we didn't get you, Dr. Bhavna. I think you were muted at the time.
Here, denial is patient is not uh, ready to accept that his wound is not going to be healed.
Okay.
So he has hope that he will get treatment and his wound will be healed by any type of medicines. Maybe it allopathic or any other.
Okay. We understand that this patient has a recurrent malignancy and he has a fungating ulcer which is not going to heal, isn't it?
So,
Yeah.
yes, this here that wound is not going to be healed.
Uh, so, have you communicated this with the patient and he's still not agreeing with the same, isn't it?
True.
Yeah.
Yes.
But he is not denying any treatment that you are offering. He is ready to take any treatment and
Now he is taking treatment. Otherwise, he was because it was told from our institute that his wound is not going to be cured. Then he went to some homeopathy or don't know which medicine, but alternative medicine. And after roaming, he has come back. And now it is wound is foul smelling and with maggots. Then we have started our.
okay. So, Smriti, I think this patient knows that he has a recurrent malignancy and he is ready to take any treatment that they are offering. So, most probably, this person would not or might be knowing that this wound is not going to heal, but still, as a coping mechanism, he is not agreeing that it is not going to heal. So, here the patient is he's obliging anything that you are offering. So I don't think we have to break this denial because he has a positive denial. Uh, he knows that it is a recurrent malignancy and the wound is not going to heal. So here I don't think we need to challenge, but I think I will also take the opinion from Smriti.
I'm not clear actually whether his concern is about his wound or the underlying or the larger illness. You know, I mean, for instance, I mean, what I'm hearing is about the wound healing, the wound healing. But does he understand the cause of the wound or the underlying condition of the wound? I mean, is his concern primarily with what he can see on his face rather than with the illness as a whole? I'm just trying to get some clarity on that.
That wound is itself a disease. Recurrent malignancy is that wound only. So if wound gets healed, then malignancy is also cured by.
But as a medical person, has that sort of been? I don't know if I'm articulating myself. Like, I understand that the wound represents the disease, but does he understand that? Does he understand that there is a life-threatening condition that this wound represents? So I'm just wondering if he's not equating this with that. So I think I think Praveen has said that, you know, it's important to break his denial. But like Dr. Sunil said, that does that need to be addressed right now? I also agree with Dr. Sunil that it's not a number one priority right now. To me, the number one priority right now would be to reduce the man's guilt, to improve his relationship with his family, to make him feel a little bit more connected to the people around him. Those would be the priorities. I find that concurrently, of course, to have the conversations with him about his illness and the illness progression. But would I put that as my number one priority right now? No, I'd put it maybe third or fourth on the list. But then, of course, I come from a different point of view. So.
Okay. So So I think what we are essentially talking about is if this patient has a positive denial mechanism that need not be broken at this stage. As Brady told, it is our duty to reduce the guilt. We should not tell him that it is because that you have gone to the other system and that has created so many problems. So we should be not touching on those aspects, and we should instead we should tell him that okay, uh, it's all over, but we will try to help you as much as possible to reduce your suffering. uh, that's what we can do to you. And maybe
And um,
yeah, yes, Pratik.
no, no, after you finish, sorry. Yeah.
No, you can go.
No, because I think Geeta made a really important point. She said only with family support can we do that. Absolutely right. I mean, we have to bring the family into this. If we are going to break this man's denial, uh, we should also make sure that the pain that revelation is going to cause him, his family is there to support him through it. So that's thank you, Geeta, for bringing that up, because we need to strengthen the family support. We need to get better dialogue between them, and then if we want to break the denial, we do that. Because once we tell him the truth, we're not going to be the ones in his home living with the fallout of that. So so we need to strengthen that family system. So that would be priority number one. And thank you, Geeta, for flagging that. So that actually helps clarify the prioritization of goals.
So I would divide the denial into two types. One is negative denial and the other one is positive denial. In negative denial, the patient would not agree with anything that we are going to suggest. Suppose this patient is not going to obey us regarding the foul smell treatment or maggots treatment, or even with the treatment of the malignancy, then it should be taken as a negative denial. The patient is not ready to accept the medical treatment. In such instances, we should take the help of the family, and we should go and tell the patient that you have this problem, and so you need treatment. But in this patient right now, as he is ready to accept any type of treatment, he is in positive denial and may not necessarily break the denial as of now. But maybe as you go on, he will have more trust in you, and when that he is having more trust, maybe you can go into that aspect. Yes, Dr. Bhavana? GCRA.
Some
We will unmute you. We will unmute you. Okay. Yeah, Dr. Bhavana, now you can speak.
Dr. Grace has asked a question: is the plastic surgery possible or not? So let me answer her. Agree. So Dr. Grace, here plastic surgery is not possible. Is the wound is not resectable.
Okay, thank you.
In chat, Dr. Grace has asked that question.
Yeah, thank you. So, in this patient, some of the medical things that we have discussed are one is regarding his mouth care. We can ask him to make a homemade saline and also to add a little bit of baking soda to spit it out every 2 hours, which is a low cost method. And maybe when he is discharged, then we can ask him to take morphine 1 hour before dressing, which can reduce the pain. And we need to find out whether this patient is in clinical depression, which needs more evaluation. And if he's in depression, he needs, I think the amitriptyline doses need to be increased, or you can, if he is in clinical depression, or else you can, if his neuropathic pain is well under control, then you may add an SSRI like escitalopram. And Smriti, can you summarize the other aspects that we have discussed, because I was not there for some time.
Yeah, so we also talked about what his life might have been before he fell sick, and he was a shopkeeper, so he was probably very social and stuff, and so all those losses have also been incurred by him. A lack of connection with the people around him. Now that the wound is not as foul smelling and not as maggot infested and stuff, probably to try and get him to engage a little bit more with the outside world. But I think the first line would be his family, to try and sort of address some of the issues that the family might be experiencing. We already talked about it, you reiterated it: reduce the man's guilt, reduce the family's guilt, not just his, but the whole family's guilt, and sort of reassure him that whatever happens, that under your care, that he's never going to be in that position ever again. So reassuring him of continuity of care and not abandoning him at any stage. With regard to the depression angle, I felt that we need to make a distinction whether the man is grieving or whether he's in clinical depression. And I mean, there are only conversation can do that. So to get a little bit more in depth about what he's missing in his life, what are the connections he's missing, and then to try and administer the spiritual assessment tool. Now, one thing about the spiritual assessment tool is, let's not use it as a questionnaire. Rather, take elements of it and work it into a conversation bit by bit. So it doesn't have to be a checklist that we go through, like, okay, tell me about your connection, who you feel connected to, tell me who not like that. So actually work it into the conversation, and that will give you a good idea of the landscape of his emotional state. And in which case, just like Dr. Sunil, you said earlier that maybe we don't need to up the analgesics if we can take care of these things. Sometimes we don't have to up the antidepressants either, if we can take care of the things that are causing him emotional distress. So yes, those are pretty much the inputs from my side. And of course, that we don't have to rush into breaking denial, but make sure that the family is ready to receive the information and receive him once he's received the information. So
Thank you, Dr. Bhavana, for presenting such a wonderful patient story. And I think you are doing all the possible things for this patient. And these are a few of our suggestions. Okay. So I think with this we can stop today's session. And thank you, Smriti, for being our faculty today and having an interactive session. And thank you, Dr. Bhavana, for presenting this patient story. And thank you all for being very interactive. And we will see you next Thursday.
Next Thursday with a topic on wound management taken by Sister Shiva. Thank you all for joining in. So I've shared the feedback link. So give a minute, do it, and then leave the meeting. Thank you, ma'am, and thank you, Dr. Ma'am.